Okay, so let's get it started. Hello, everyone. My name is Dr. Yasuhiko Kamura. I'm a board certified endodontist. I'm very honored to have this opportunity to give you a lecture about Endo-Perio. The title of this lecture is Endodontic and Periodontal Interrelationship Demystified. There's a reason why Dr. Miyamoto asked me to give you a lecture. So I am a partner at Sigma Dental Specialists in Dallas, Texas. We have 7 endodontists and 3 periodontists. Practice limited to endo and perio. We have 6 offices all over Dallas and we'll open one more soon. If you want to join us soon, just please let me know, email me or call me anytime. I would love to talk about endo if I have a chance to do that as well. Being an endodontist, I have been treating many root canals every day. As I mentioned, we are on Endo-Perio team. We see plenty of Endo-Perio cases as well. So when you see this kind of case, what do you do? Do you think this needs a periodontal treatment or the endodontic treatment? Maybe both. I think you'll be able to find the answer at the end of this lecture. You see the very deep periodontal pocket on the mesobuccal, and also there's a sinus tract at the marginal portion that can be traced all the way down to the apex of the mesobuccal root. You can also see the cone beam CD, that is a deep bone loss on the mesobuccal root, and also periapical radiolucency mesobuccal and also distal buccal. I will discuss these today. Definition of endoperio lesion, classification of endoperio lesion, treatment and prognosis, and cases. Diagnosis is often challenging because these diseases have been studied as separate entities, and each primary disease may mimic clinical characteristic of the other disease. Before we jump into endoperio, I would like to talk about the etiology of endodontic disease. A periapical lesion ensued after pulpal inflammation and necrosis. Let's talk about the process one by one. Microorganisms in caries produce toxins that penetrate into the pulp through the tubules. Studies have shown that even small lesions in enamel are capable of attracting inflammatory cells in the pulp. When bacteria or the byproducts of bacteria reach the pulp undergoes the inflammatory response. As you all know, there are 5 cardinal signs of inflammation, and similar signs happen in the pulp. However, the pulp in a different environment than other tissues. The pulp is located in the hard tissues called dentin, as you all know, and it is called low compliance environment. Of the 5 cardinal signs, the swelling occurs in soft tissues. But what happens when swelling occurs in the pulp, surrounded by hard tissues, like dentin? The swelling in the hard tissues turns into intrapulpal pressure, which complexes the pulp blood vessels, especially the venules, and obstruct the blood flow. As a result, pulp blood flow is blocked, and the pulp tissues becomes no blood flow. That is defined as pulp necrosis. Again, pulp necrosis is a lack of blood flow in the pulp, not the nerve is dead. The lack of blood flow means that the host immune cells do not reach it. The root canal system is now providing a safe haven for bacteria. In addition, the bacteria can feed on the necrotic pulp, and also the moist environment oxygen concentration makes the root canal system a good place to live for bacteria. Then it invades inside of the root canal to the apical portion like this guy. And finally, the inflammation spreads to the outside of the root canal system, and clinically apical periodontitis develops. As I mentioned now, apical periodontitis is an inflammatory lesion in the periodontal tissues that is caused mostly by bacterial elements derived from the infected root canal system of teeth. In non-treated teeth, apical periodontitis represents a defensive response to the primary infection in the necrotic pulp. These bone resorption are caused by osteoclasts that are activated by inflammatory mediators such as IL-6. This video, I thought like it's very interesting. This video shows that our cells, like macrophages, are capable of kill bacteria and even cancer cells. I think you'll be able to download this Facebook page. So you'll be able to try it, to download it. It's a very interesting video. Now, you know what is the etiology of endodontic disease? We'll talk about the definition of Endo-Perio lesion. There are two definitions. One is from a periodontist, the other one is from endodontist. So the first one are from periodontist. EPL are clinical condition involving both the pulp and periodontal tissues and may occur in the acute or chronic forms. So the other one is a process involving interaction of disease of the pulp and periodontium. They are easy to say. However, the diagnosis is often more complicated than you think. So next, we're going to talk about the classifications. There are some classifications of Endo-Perio lesion. I'll discuss two of the most notable classifications today. One is Simon's classification. The other one's a new classification from AAP. As an endodontist, I have been utilizing the Simon's classifications. If you think, if you, let's say, ask Dr. Miyamoto, like periodontist, they will use the AAP classification at this point. Simon published this article in 1972. It's a very classic, very old article. He classified Endo-Perio lesions based on both clinical and radiographic findings. He classified these defects into three primary types: pulpal origin, that is also known as endodontic lesion with secondary periodontic involvement, and periodontal origin, that's a periodontic lesion with the secondary endodontic involvement, and endodontic periodontic origin, also known as a true combined lesion. So they are the three categories, like classification. Primary endo, secondary perio lesions develop from the long-standing apical pathology, expansion of the infection colonially along the periodontal ligament destroyed the adjacent bone until reaching the marginal periodontic. Clinically, pulp necrosis expected, and periodontal attachment loss is noted. Periodontal probing depth are often narrow. Swelling or the sinus strap may appear more colonially located. Radiographically, bony distraction is often visible from the alveolar crest to the apical region. Next, the primary perio and the secondary endo lesion result from extension of the periodontal pocket along the root structure to the apical foramina or the lateral canals. You'll be able to see this one here, right? Yeah, pulp voltage is compromised, but possibly vital. It's primary perio. Radiographically, extension of the intrabony defect is visible to apical foramina. Finally, this is a true combined lesion here, a result from the coalescence of independent periodontal and endodontic lesion. Clinical and radiographic findings are often similar to those noted from primary perio, secondary endo lesion. Clinically wide periodontal pockets and a non-vital pulp are present, and radiographically an apical marginal bony defect is visible. This is Simon's classification. This is a new AAP classification. It criticizes about Simon's classification. It says the main drawback of Simon's classification was to base their categories on the primary source of infection, such as root canal or periodontal pocket. This seemed to be a suitable approach, as the lesion of a periodontal origin might have a worse prognosis than those of endodontic origin. Nonetheless, using history of the disease as the main criteria for diagnosis was not practical, because in the majority of the cases, that complete history is unavailable to the clinician. Basically, what they are saying is this: you're gonna have to guess what it is by if you do with the Simon's classification. That is true. And this new classification based on the present disease status, everyone can make a diagnosis for this criteria. It's easier. Yes, it is easier. As I discussed, there are these two classifications, but then endodontists will still use the Simon's classification. AP classification is easier for everyone to make a diagnosis, as I said, because it is based on the present clinical status. But Simon's classification is not. You just need to determine if it is primary endo or the primary perio. Now, how do you know this is primary endo or the primary perio? Formulating the differential diagnosis among endo-perio lesion has been challenging because most often clinicians do not have a complete history of the course of disease progression. Therefore, diagnosis steps should include patient-reported dental history, visual inspection for presence of sinus tract, and severe inflammation in association with a large restoration and anatomic abnormalities such as palatal groove, radiographic confirmation with tracing the sinus tract. Result of the clinical findings, including percussion and palpation, routine periodontal assessment for presence of mobility or the deep probing depth, testing for coronal cracks, and the pulp vitality test. Let's see one of my clinical cases together. 28 years old male, cold negative, very sensitive to percussion, palpation negative, probing depth at 8 millimeter for buccal. Furcation grade 2 and mobility grade 1. What do you think? It is primary endo, or maybe primary perio, or maybe combined lesion? I will share the classic article here to assist the diagnosis process. This article was published in 1972 as well, but still provide us a valuable information how to determine the etiology of the lesion. If the pain is severe and especially temperature related, but I think it is, of course, it is most likely related to endo, you can differentiate the source of the pain that leads to your primary source of the infection. You say that determine whether periodontal or the endodontic treatment should be instituted. Pain, the presence of the pain usually indicate endodontic involvement, especially if the pain is severe. So it says that perio doesn't cause that much of pain. Yes, sometimes, yes, they are, but usually the endodontic pain is a little bit more, intense. So that's what it says. So the types of pain and also the severity of the pain as well. You can determine whether this is endo or the perio, you can guess. And also radiographic findings. There are radiographic differences between endodontic and periodontic lesion. If it is of periodontic origin, other teeth besides the one in question manifest involvement. If the periapical lesion is present, which does not communicate with the periodontal pocket, then it is endodontic origin, right? This is very easy. And now this article was published in 1972. They are talking about two-dimensional radiographs like PA. As you all know, we now have a CBCT. Should we use it? Is it helpful to make up endo-perio diagnosis? What do you think? Yeah, the answer is of course, yes. It is very beneficial to have a CBCT for endo-perio diagnosis and treatment planning. This is AAE and the AAOMR joint position statement. See recommendation 2. Limited FOB CBCT should be considered the imaging modality of the choice for diagnosis. Patients who present with contradictory or non-specific clinical signs and symptoms associated with untreated or the previously endodontically treated teeth. So please don't be afraid to take CBCT as needed. Most of the cases, you're able to find the valuable information there. And also swelling. The types of swelling often aids in the differentiation between endodontic and periodontic lesion. If the swelling is the apical portion, this is endo. If the swelling is along the marginal periodontum, it could be perio. So the location of the swelling helps us. And pulp test findings. Of course, this is coming from endo. the pulse should be necrotic. But if it's coming to perio, it could be vital. And sinus tract with opening on the most mucosa opening on the mucosa are most often related to endodontic problems. On occasion, however, they may open into the circular region. Yes. So like this drawing, usually like the sinus tract is coming to the side, but that could mimic the periodontal pocket. So the sinus tract trying to find a way to like less pressure and trying to get out, right? If go with the periodontal ligament, the root, along with the root, that could mimic the periodontal pocket. That could cause primary endo and secondary perio cases. So this is a chart for differential diagnosis between pulp bud and the periodontal disease. They are very confusing sometimes, but if you know these criteria, you'll be able to find the answer and you make a proper diagnosis as well. Return to this case, looking at the X-ray, he's very young patient as well, 28 years old. The bone resorption large at the apex and the small at the coronal portion. And it is a bone resorption for like a growth. Also being young and having no periodontitis elsewhere. Furthermore, it is also a point that the prosthesis is applied only to the first molar of the lower jaw, right? Crown only applied on the lower jaw. Why is the bone resorption occurring only there? From this, it can be predicted that the periodontal pocket is from endodontic origin. This pocket is actually the sinus tract, mimicking the periodontal pocket. In other words, since it is primary endo, it can be healed only with endodontic treatment. This is 4-month post-op. After the root canal treatment, PN, CBCT, this case was healed with only endodontic treatment. Periodontal treatment might cause excessive damage to the periodontal ligament that may compromise the prognosis for the tooth. So if you misdiagnose, let's say this is primary perio, this is a perio lesion, and do a lot of scaling, root planing, that could cause the periodontal ligament damage that could compromise the tooth prognosis. So you're gonna have to make a diagnosis before we jump in for the treatment. It is very important. That periodontal pocket does not always need a periodontist. Sometimes need an endodontist. The treatment of endodontic, periodontic, or combined lesion may require both endodontic therapy and the periodontic regionalized procedure. But if it is primary endo, most of the cases will be healed without any periodontal treatment like I just showed you, because they are just endodontic disease. That being said, the treatment and prognosis are all depending on the etiology of the lesion. We discussed the Simon's classification. How to determine the prognosis of this condition? Primary endo depends on endoprognosis. Primary perio lesion is depending on mostly perio, usually have worse prognosis. True combined lesion always have questionable to poor prognosis. Overall, the prognosis of Endo-Perio lesion is associated with periodontal conditions. Increased periodontal disease resulting in decreased predictability. Lesion with combined lesion or the primary perio cases require both endodontic and periodontic therapy. And endodontic therapy should usually be completed first. So sequence of treatment is very straightforward. This was published from Journal of Endodontics, 2009. This shows a sequence of treatment for Endo-Perio combined lesion. Once the therapeutic prognosis of the periodontal regionalized procedure determined to be favorable, the endodontic therapy is provided. And wait 3 months for periapical tissues to be healed from endodontic infection. Once the periapical healing is confirmed, we can consider moving to periodontal treatment. But if we cannot see any periapical healing, what's going to happen is you may have to just consider extraction, or we can do like retreatment on the root canal, see if that's going to help. But usually like the prognosis won't be good. It's questionable to poor. So we may have to consider the extraction if the periapical tissues healing or not confirmed after the root canal endodontic treatment. So this is published by AAE. This is treatment constellation. The prognosis depends on the periodontal condition, not endodontic pathosis. You can see favorable, questionable, unfavorable. The endodontic condition will be the same. The tooth exhibit the pulp necrosis and the isolated bone loss to the involved tooth or the root, right? But you see favorable, normal periodontum, questionable, moderate periodontal disease, unfavorable, advanced periodontal disease. So finally, let's go over cases together. First of all, I'm going to show you primary endo and secondary perio. So go back to the first case I showed you. This is 49 years old, healthy female patient, non-vital pulp, bone loss is isolated on this tooth. Looking at the shape of the bone loss, this can be diagnosed as primary endo. The pocket is just a sinus tract, mimicking the periodontal disease. Now you can tell this is not really need a periodontist. This just need a root canal. So I treated this case, and actually I treated a month ago. I still waiting for the follow-up, but I'm pretty sure like this will be healed. I confirmed the sinus tract was healed. I did a one visit root canal. My root canal treatment, endodontic non-surgical root canal, is 90% or one visit, and I'm doing a single point technique with a bioceramic BC sealer. So again, this was done a month ago. I'm still waiting for the follow-up X-ray, and again, like she hasn't returned to our office. That means there's no issues at this point. And if there's bubble like swelling, and she will come back. But again, I'll follow you up. Like hopefully I have a chance to show you guys the follow-up X-ray as well. This case, this was very young female patient as well. She was actually 18 years old. Diagnosis was pulp necrosis with chronic apical periodontitis. And there was no actual sinus tract, but there's a deep periodontal pocket on the buccal, mesial buccal and distal buccal. So there's a deep pocket all the way down to the apex. You see the shape of the bone resorption? Very similar to what I showed you previously. There's no periodontal pocket anywhere else. It is conclusive to say this is primary endo. We did root canal treatment for her, and the other one is the ear follow-up. Periapical radiograph and the CBCT showed a complete resolution of the previous vertical defect. The remaining pocket depth was reduced from 8 to 3. That's a normal, within normal limit, without any gingival recession. No bleeding on the probing was found. The patient was very happy, and patient was periodontally maintained at 4-month interval throughout the entire treatment by her general dentist. This is a very nice case, especially like young patient. There's no bone loss or periodontal, condition on other location. Then we're gonna have to think about this is most likely caused by the endo. And you see deep filling on tooth number 19 as well. This is very conclusive. And actually it healed. It was healed. So next case, this case was also very young patient. I thought like this was mid-30 female patient, and deep filling on tooth number 30, and diagnosis was pulp necrosis and chronic apical abscess. So there was a sinus tract, multiple sinus tract. There was at the portion, of course, the deep periodontal pocket, and also on the side of the gingival. There was a sinus tract as well. Now, so I thought this was a primary end case. So I did a root canal, and according to that, we're gonna have to wait 3 months for the periapical healing. You see, like we took the CBCT, yeah, we may be able to see slight healing of periapical tissues, but looking at this condition, I cannot say this is healing. It's very questionable. So what I did is, I have to refer to the periodontist to see if regional like endodont, periodontic condition can be considered, or the extraction may have to be considered. But again, looking at this case, I don't see the clear signs of periapical healing. So according to the O's criteria, like sequence of treatment, we may have to recommend the extraction for her. So even though I thought this is primary endo, this didn't work out well with the root canal. So we always have to tell the patient, we'll try to do it because there's a deep periodontal pocket, could be, mimicking the sinus tract. This is could be coming from the root canal, but prognosis may be always questionable to poor. It's safe for all the clinician to say, but if it heals, like, you'll be appreciated by the patient. As indicated by the term, apical periodontitis, the lesion typically develops near the tips of roots, where the root canal communicates with the periodontium via apical foramina. Inflammatory periodontal lesion of the endodontic origin may also emerge at the other anatomical or idogenic openings, which may be present in the lateral aspects of the roots or in the furcation of the multi-rooted teeth. In this instance, the causative agent are released along lateral of the accessory canals. This led to the more comprehensive term, periodicular lesion. Since most of portals of exit are in the apical portion of the roots, and for the sake of convenience, the term periapical or the apical lesion is used in this text to designate all inflammatory lesion of endodontic origin in the periodontum. You see, if there's the lateral region, it's, as an endodontist, I've in many cases like lateral canals and the lateral region, but it's very hard to determine this is actually coming from the lateral. Sometimes, like this case, you see the lateral lesion, and also you see a little bit like the bone, the root canal space, maybe like resorption, maybe the perforation. And CBCT taken like this is a wide, large area with the lateral radiolucency. This was 45 years old male patient. The diagnosis was previously treated with a chronic apical periodontitis. There appeared to be some alternation in the root canal anatomy in the coronal third of the mesial root canal. There was slight expansion that resembled possible perforation, maybe internal resorption, and radiolucency around the furcation. There's 7 millimeter at the mesial, the periodontal pocket, mesial buccal root, but there's no periodontal pocket anywhere else. So it's a very healthy condition. Periodontal conditions looks very good, except this tooth. So it is most likely caused by the endo origin. But again, like there's a perforation once I go inside. Once I went inside the root canal system, there was a perforation. So the bone resorption was caused by the bacterial infection that was compromised by, initiated by the perforation. Treatment plan was perforation repair and the root canal retreatment on this one. So this is a year follow-up periapical radiographs. It showed complete resolution of the previous vertical defect. The remaining pocket depth was reduced from 7 to 3. So this was a total heals. And even though the prognosis was not the best, pre-op, but this was healed with a very good condition, and the patient was very happy. And yeah, so this is a good case. And even though the prognosis looks not the best, sometimes it's here. Like if you make a proper diagnosis, this is coming from the root perforation and primary endo. So if you can do that proper endodontic treatment, that's going to heal the body to the better way. And no bleeding on the probing was found. The patient was periodontal maintained at the 4-month interval throughout the entire treatment by his general dentist as well. So this case is not Endo-Perio case, but you can see the lateral region. A very unique anatomy. This was one of the best cases I've ever treated. It looks very good. And these lateral anatomies are usually not instrumented, but chemically disinfected as much as possible. Some of the cases, you can see the sealer penetrate into the lateral canals like this case. We call the sealer path. It's, looks very good. There's a curve, it's curved like lateral region. It's very good, beautiful case. This one is a lateral canal as well. It could cause an Endo-Perio lesion if this lesion is progressed coronary, but it didn't yet. So that was good, but this like lesion, easier for the infection to get out from the inside. It's closer to the coronal portion. If it is only apical portion, it takes time to be Endo-Perio lesion, right? But if it is furcation or like I showed you the perforation, it could cause it easy for the bacteria to get out or the infection to get out from the bone. So that could cause the Endo-Perio. Almost Endo-Perio lesion, right? So you see the big bone resorption, periapical radiolucency, and this didn't have any periodontal condition, periodontal pocket, or the sinus tract. So we did a root canal. In 6 months, it healed. I can see the complete healing. Beautiful case as well. And this was almost Endo-Perio lesion as well. It's a big lesion, periapical radiolucency. But you see like you see the quality of the root canal pre-op, and lower side is a year follow-up. The quality is not very good, very not dense. The root canal filling is not adequate, and you can see the coronal restoration. There's the lack of filling. I don't see anything. There could be some like radiolucent filling inside, but I doubt it. And I started, even though like the lesion is very big, we started the root canal. And this after the root canal without any periodontal condition, like only the non-surgical root canal, a year follow-up, you can see the complete healing. And there's a like C-shaped canal. We cleaned out all the way, we placed a filling, and that heals everything, human body. I will show you the primary perio cases as well. So this patient was referred to our office for endodontic evaluation. 45 years old female, pain on biting on tooth number 3, pulp was determined non-vital, according to the pulp test. I did the cold test and the EPT. There is also 8 millimeter with periodontal pocket at the distal buccal. PEA does not show the conclusive signs of bone loss, initial diagnosis of pulp necrosis, and symptomatic apical periodontitis from endodontic standpoint. So I thought this is a root canal. This is endo things, but this could be mimicking the probing that could be mimicking the sinus tract. So I thought it is coming from endo origin. But once I took the CBCT revealed the true nature of the bone loss. The tooth was thought to have primary periodontal involvement from the pattern of periodontal bone loss with the wide base coronary and the narrow extent apically, coupled with the general marginal periodontitis elsewhere in the mouth. the periodontal prognosis was determined as poor to questionable according to the prognostication system of Avire. Patient elected extraction and implant. And I agree. And this was the primary perio, and the bone loss has been progressed, the apical portion that has been causing the pulp involvement, endodontic involvement. But the perio, primary perio, it generally is rare for us. So if we can see this kind of case, usually like the perio is already advanced. So the prognosis is not very good. So lastly, I'm going to show you the true combined lesion, like this case. So she was referred to us with the possible endodontic treatment. But as you can see from the PA, before I don't even need to take the CT scan for this one. It's a very, deep bone loss, and also I can see a little bit of the periapical radiolucency on distal root, the apex of the distal root. So endodontic periodontal combined lesion is a true challenge. Its management requires, understanding of the wound healing process involving both endodontic and the periodontal complex. But the prognosis is not good, so extraction will be the first option in this kind of case. I'll show you a little bit of the differential diagnosis as well. First, root fractures. I see many cases. Some people say that after the COVID, a lot of people like clench, line like, yes, I feel I've seen a little bit more fractured cases. Like last week, I have like 3 or 4, and CBC shows a complete fracture. So maybe, but there's no like specific evidence I can show you right now. So root fractures, especially a vertical root fracture, present particular problems in diagnosis. Symptoms and signs associated with vertical root fracture are frequently difficult to distinguish from those associated with periodontal and endodontic lesions. As you can see, this picture shows a vertical root fracture, deep periodontal pocket, and localized distraction of alveolar bone are often related to long-standing root fractures. Diagnosis of vertical root fracture is often difficult, but CBCT and the microscopic examination will help to make a proper diagnosis most of the time. If not, sometimes a definitive diagnosis of vertical fracture has to be confirmed by surgical exposure of the root for direct visual examination like this case. So extraction is indicated for most of the vertical root fracture cases. You may be able to do like the root amputation as well if the tooth has a multiple roots, like upper molars or like lower molar, but there's a root fracture, right? If you cut the root, what about the other root? Like it could be fractured as well. So I don't do that much root amputation if there's a vertical root fracture. Some people do, and also if the patient patients want to save it, we can try, but that's not going to be the first option for me. So what do you think about this case? It looks like a pure endo lesion, right? You can see the CBCD. It has a deep periodontal pocket on the palatal. What do you think this is? This is the lateral incisor. This is number 7. Diagnosis was previously treated and chronic apical periodontitis. And looking at the shape of the root, actually this picture is not the same case, but they are the same palato-gingival grooves. They are developmental anomalies of the maxillary incisor teeth. Kramer reported that the 0.5% of teeth examined had a palato-gingival groove extension to the root apex, thus contributing to an endodontic pathologic condition, like the case I showed you. Clinically, these groups may be asymptomatic or symptomatic periodontal problems may occur. It is thought that the pulp of these teeth may become secondary involved and demonstrate the symptoms of pulpal disease, exactly like a primary perio, secondary endo. But etiology is more related to this anatomic structures, not actually coming from perio. This is coming from the groove. This is a compilation of the studies of endodontic outcomes with the generally good outcomes reported, like more than 80. Like if it is without apical periodontitis, it could be higher than 90%. So the prognosis of primary perio is questionable, but primary endo should be good because it based on the endodontic prognosis like these outcomes. And secondary and primary perio and secondary endo disease only happen when the perio is advanced. On the other hand, again, the prognosis primary endo is generally good. Basically, they are the endodontic disease. Endodontic and periodontal lesion result from the close interrelationship of the pulp tissue and periodontum. The major pathway of communication between the two types of tissues are the apical foramina, lateral and accessory canals, and dentinal tubules. The differential diagnosis of endodontic and the periodontal lesion is not always straightforward and requires clinical data accumulation from the number of diagnostic tests to obtain the correct diagnosis. When examining and treating the combined or the individual lesion in endodontic and periodontics, the clinician must bear in mind that the successful treatment depends on the correct diagnosis. Lesions when the combined causes require both endodontic and periodontic therapy, and endodontic therapy should usually be completed first, as I explained to you guys. Root resection and regional techniques offer alternative approaches, enhance the clinician's ability to deal with these complex clinical problems. So that concludes my presentation. Actually, I have a Facebook page and an Instagram page. So I post, I try to post like, weekly and hopefully daily. And if you like to follow, please do. And I really appreciate your time. And also thank you very much, Dr. Miyamoto, for this invitation, and hope to see you guys, soon in person. Thank you very much again.